Hello to everyone out there. We're just going to wait until about 3:05 to get going, just to allow people some time to trickle in. All right, well, I have 3:05, so I guess we can get started if that's okay, Tracy. Or do you?
Nope, I think we're good.
Perfect. So welcome to year 3 for the dry workshop in serology. Thank everybody for joining and for participating in the workshop questions. For those of you who haven't participated in the earlier 2 tiers, just kind of a way of introduction, my name is Jonathan Mack. I'm a physician, medical officer with Canadian Blood Services, and also work with the diagnostics lab. And I'm also a transfusion physician and hematologist at the Ottawa Hospital. The sort of structure for the session, this third session, we're just going to go through all of the cases and questions that were distributed as part of the workshop. Go through the responses that were submitted, and then some of the key concepts involved in answering each question and the suggested best answer. With each question, there'll be some time probably to do it question by question if there's any comments or questions about the rationale or the question itself. You can always just put it into the chat or raise your hand, and we'll deal with it kind of as we're discussing each question. And then there should be some time at the end if there's other questions or concerns that come up. So I guess with that, we can just get started. So for case 1, is a 24-year-old woman with sickle cell disease who's admitted with hypertensive crisis and renal failure. She's been transfused previously. She has a red cell phenotyping that determines she's group A, R prime, and K negative, and her antibody screen is negative. Question 1, which of the following would be most appropriate if red cell transfusion is requested? And you'll note on the slide here in red, there was an error I noticed in the responses when the worksheets were returned that I think happened just because of auto capitalization. So my apologies about that, but it should have read little c negative and not big C negative for options B and D. So just again, apologies for that. There was one error made, I think, in each tier, so tried to spread them out evenly. The options here for red cell transfusion, which would be most appropriate, group A RHD negative, so kind of standard matching for antigens. Group A RHD negative, little c negative and big E negative cells. Group O RHD negative, big K negative cells, or group A RHD negative, little c negative, big E negative, and Kel negative cells. As a reminder, on the side here, the patient herself is D negative, C positive, little c negative, big E negative, big E positive, little e positive, and big K negative. In terms of responses we got, most people answering kind of the most complete option for matching. So RHD-CE matched group A and Kel negative cells. People worried just about being RHD negative and Kel negative, and then a few people being for the other two responses. So concepts behind this question that are important, it really gets down to red cell phenotype matching in sickle cell disease. So we know that RBC antigen alloimmunization is common in patients with sickle cell disease and much more common than other patient groups. Anti-Kel, anti-big E, and anti-big C are the most commonly observed alloantibodies. And data that we have with comparing extended matching to standard matching for allo transfusions suggests that you can decrease the prevalence of alloantibodies from 30% to 10% by matching for the RHCE, CE, and Kel systems, in addition to the standard ABO and RHD matching. And so that's a practice that's recommended by the American Society of Hematology guidelines, and I think adopted by most Canadian centers. So when we look at of the options that were available, which of the options sort of matches that requirement best? It's going to be option D, because that's the only option here that's going to take into account patients' RHD, CE, and Kel status. So the other options either ignored both of them for option A, ignored the Kel status for option B, ignored the CE status for option C. So D would be the best answer there. And take into account the error in the slides. So for on case 1, her hemoglobin falls to 55 grams per liter. So a decision's made to transfuse group O RHD negative RBCs, and she's discharged from hospital on antihypertensive medication. Again, because she presented in a hypertensive crisis. 8 days later, she presents to the ER with fevers, and antibody screening is repeated and shows the following results summarized in the panel. So what we're seeing on this panel is mixed reactivity, both at immediate spin and at IAT phase, but with similar reactivities between the two of them, and an autocontrol that is positive, 1+. Question 2 is, why is the autocontrol positive? So she's got option A is because she has an autoantibody with a relative big E specificity that's developed. B, because she's developed a drug-dependent antibody to an antihypertensive drug. C, because she's got a delayed hemolytic reaction following the RBC transfusion. Or D, because hemoglobin S is causing agglutination in vitro. In terms of responses we got, most people picking delayed hemolytic reactions. A few people split between an autoantibody with relative big E specificity, or a drug-dependent antibody to an antihypertensive drug. So if we again look at the panel, we can see when we look at the specificities that we're seeing through our rule-outs, that we can't rule out a big E, and we can't rule out a big S. There aren't any V, KPA or JSA positive cells to worry about, but those obviously wouldn't explain the reactions we're seeing. And when we look between the big E and the big S, every reaction that we're seeing is explained by one or the other of those two antibodies. So there looks to be a big E antibody and a big S antibody that are appearing. And the autocontrol is positive. So why is that positive? Well, remember, she was just transfused, and the unit of RBCs that was given was group O RHD negative. So we don't know anything else about the status of those RBCs in terms of the big E or the big S status. We might be able to infer some things or assume things for the big E status, but nothing for certain. And she's now showing a big E and a big S antibody, and the autocontrol is positive. So it's most likely that this is representing a delayed hemolytic reaction, where the antibodies weren't detectable initially, and that transfusion event stimulated an anamnestic response. She's now got antibodies showing up quite quickly afterwards. It's unlikely that an autoantibody with relative big E specificity is developed, mostly just because we're not seeing pan reactivity that we'd expect with an autoantibody classically, and that wouldn't explain the big S reactivity and specificity that we're seeing. A drug-dependent antibody is a possibility, especially with antihypertensives as a class of medications, although most of the drug-dependent antibodies that are specific to antihypertensives are from methyl dopa, which isn't really used all that commonly. So that's a little bit less likely just from the perspective of the drugs that she's likely been exposed to, but also because we're seeing reactivity not just with the autocontrol, but with all of the test cells as well. And so drug-dependent antibodies would not be expected to be causing this kind of reactivity with panel cells in most cases. We'd expect it to be just a positive autocontrol, but no reactivity with other cells, the test cells. And then hemoglobin S causing agglutination in vitro, that's not really something that we see as a problem with hemoglobin S. So it doesn't cause the sickling, but doesn't cause the agglutination to happen in vitro in the samples. So option C being the best answer there. Question 3, her hemoglobin is now 50 grams per liter. So another unit of RBCs is requested, and just the time course again, she was at 55, was transfused, and now is at 50. Which of the following should we pick to be issued for this patient? Knowing now that she's got a big E antibody and a big S antibody. So either a group A Rh negative, E negative, S negative unit, a group O Rhd negative, big E negative, S negative unit, a group A E negative, S negative unit, or a group A Rhd negative, E negative, S negative, and Cal negative unit. So almost everybody responding the Rhd, E, S, and Cal negative unit, because the best answer here. Again, we've demonstrated she's got a big E antibody and a big S antibody, so we want to respect these, but we don't want to forget about the other phenotype matching that's important that we talked about for sickle cell patients to prevent them from making other antibodies. So the Cal system, the D system, the RHCE systems all need to be respected in addition to whatever antibodies are there. So that would mean we'd still want to respect the RHD, want to issue an RHE negative unit, an S negative unit, and a Cal negative unit in addition. So all of those need to be respected because of the phenotype matching and because of the antibody combination that's present. So an additional unit of cross-match compatible RBCs is transfused, and the next day her hemoglobin is 42. So it's now dropped from 55, went to 50 with 1 unit of blood. Another unit was given and it's now 42. And there's evidence of hemolysis. A direct Coombs test is negative. The question is, which of the following would we expect on repeat antibody screen? The options being an anti-big E and an anti-big S antibody, which is basically what we were seeing before she was transfused a third time. Development of a new anti-C, big C, along with the anti-big E and the anti-S. An anti-big E and an anti-K now, or an anti-big C and anti-big E and an anti-S as well. Two answers are the same there. So in terms of responses, most people expecting to have the same results as previously. A few people expecting some changes with either a big C appearing or a big K appearing. So in terms of the best answer, I think most people got this one, the anti-big E and the anti-big S. Why is that? So what are we thinking is going on here? So we've got a patient whose hemoglobin keeps decreasing despite transfusions, and has, even despite 3 units of RBCs, has had their hemoglobin drop to 42, lower than they were prior to any blood transfusions. So I'd be quite worried in this case about a delayed hemolytic reaction and possibly even hyperhemolysis. So what these are potentially life-threatening delayed hemolytic reactions that can occur following transfusion. We see them most often in patients with sickle cell disease, although it's not the only situation where they can occur. Risk factors for them are having a history of alloantibodies, a history of a delayed hemolytic transfusion reaction, and if the transfusion is being given for an acute illness or an acute event in hospital. So those are all risk factors for having one of these delayed type hemolytic reactions. with or without hyperhemolysis. The hyperhemolysis aspect is of concern or suspected when the transfused there's evidence that the transfused cells and autologous RBCs of the patient are being hemolyzed. So the kind of pattern we'd see in that to diagnose it would be evidence of hemolysis following a transfusion, with the hemoglobin decreasing below whatever it was before the transfusion was given. So suggesting that it's not just the transfused cells that got destroyed, but they're actually dropping now below what they were before they're being transfused. And the DAT doesn't have to be, but it's usually negative in these cases. So you're not seeing necessarily alloimmunization happening, or sorry, red cells that are coated with IgG. They're all being destroyed. It often occurs in patients that have been previously alloimmunized, so that's where this risk factor of having a delayed hemolytic reaction comes in, and having a history of alloantibodies. But it can occur even if you don't have previously detected alloantibodies. So someone who's got a fairly clean screen can still be at risk of developing these delayed hemolytic and hyperhemolysis type reactions. And the most worrisome or challenging aspect about them is that they're worsened by additional transfusions. So giving more blood can actually make things worse by prolonging the hemolytic reaction and the hyperhemolysis. So it's a situation where patients can get quite anemic, and giving blood is just going to worsen things. So transfusion support is really kind of not an option. Really challenging to deal with clinically. So with that background, I guess in terms of this, getting back to answer this question, what would we most likely expect on this? So we know the patient had the anti-big E and the anti-big S. They've been transfused cells that have been cross-match compatible. We don't know what their phenotype was, but we wouldn't expect there to be development of new antibodies so quickly. So that makes answer B and D really not likely. And same thing with anti-Kel, we shouldn't really be expecting that to happen right away. And we wouldn't expect the anti-big S to be going away. So point to emphasize here is really that with these delayed hemolytic reactions, we're typically expecting not any new antibodies to be formed. The hyperhemolysis is a result of the stimulation of the immune system and some of the off-track or off-target hemolysis that can develop as a consequence of that. Question 5. So which of the following conditions is most likely causing progressive anemia? So hemolysis of sickle cells, occult bleeding, incompatible blood transfusion, or hyperhemolysis syndrome. In terms of responses here, we had most people picking hyperhemolysis syndrome. Next most common answer being hemolysis of sickle cells, and then incompatible blood transfusion being suspected. So I think hyperhemolysis, as we kind of went through in the other questions, probably is the best answer here. In terms of the other options, the hemolysis of sickle cells is a possibility, although it's a pretty rapid destruction of cells. And given the history of repeated transfusions, it would be more worried about hyperhemolysis being of concern rather than there being hemolysis of sickle cells alone. I think it'd be hard to kind of suspect this given the transfusion history and the rest of the pattern, but it's a possibility, just it's not typically seen as dramatically with hemolysis of sickle cells alone. Same kind of rationale for occult bleeding. It's a pretty rapid decrease in hemoglobin for occult bleeding, and we have evidence of hemolysis in the question stem, so that wouldn't really be explaining if occult bleeding was going on, we would be expecting evidence of hemolysis. And then the incompatible blood transfusion, for all of the units that were given, it was emphasized that they were all cross-match compatible. So we're not expecting there to be any incompatibilities that were known about beforehand. I guess they were sort of potentially incompatible blood transfusions because of the delayed hemolytic reactions, but they weren't by definition like incompatible at the time they were given. So hyperhemolysis is kind of the best answer for this one. So pause there, I guess, to see if there's any questions about that case before we go on to case 2.
Yeah, we do have a question. So would you provide hemoglobin S screened units?
Good question. So ideally, you would provide these hemoglobin S screen units for patients with sickle cell disease specifically. just to avoid contributing, especially in an acute setting where you're going to be potentially putting in more sickled cells into an environment where there's already sickling going on, you may decrease the therapeutic benefit. But if it came down to a question of appropriately antigen matched or hemoglobin S, like a hemoglobin S sickle trait unit, the antigen matching should take precedence. Okay, case 2. So there's a 54-year-old man with chronic lymphocytic leukemia who's admitted with shortness of breath. Hemoglobin is 61, an LDH that's elevated at 788, a haptoglobin that's undetectable, and a bilirubin that's elevated at 87. And the patient has received a transfusion of RBCs 6 weeks prior. We have antibody screening results and a direct Coombs test that are shown. Some notable things on this screen is there's a pan-agglutinin at the IAT phase with a positive autocontrol, and the DAT is positive 1+ for the poly and 1+ for the IgG, negative for complement. So pattern overall here looks like we've got evidence of hemolysis, anemia in a patient with underlying CLL, which is a risk, a condition that often gives autoimmune cytopenias, so both autoimmune hemolytic anemia and ITP. And we're seeing a pan-agglutinin with a positive autocontrol and a positive DAT, so it looks pretty compelling for autoimmune hemolytic anemia. Question here is, which of the following can result in a false positive direct Coombs test? Options being in vitro coating of RBCs by complement, IgA or IgM coating of red cells, red cell incubation with the Coombs reagent, or presence of hemoglobin S. The responses, there's a bit of a mix of responses we got here. Not many people worried about hemoglobin S being present, but a few. False positivity being caused by incubation with Coombs reagent by a few. IgA or IgM coating of red cells being the most popular. And then in vitro coating of RBCs by complement by a few people as well. So in terms of bit on the direct antiglobulin test, reminders on this. So it's a test that detects the in vivo coating of RBCs with either IgG or complement. So red cells taken from the patient, tested, and if they have IgG, it'll test positive for IgG, and then complement with complement. After they're washed, the RBCs are mixed with the anti-human globulin reagent, centrifuged, and then the sample is checked right away for agglutination. False positives with this testing can arise because of complement deposition in vitro. So if the sample is allowed to sit in the plasma too long and you get non-specific complement deposition on the red cells, that can give you a false positive C3. If there's aggregation by gel in the serum separator tubes, it's causing clumping of the cells. That might give you a false positive that's not truly related to antibody or C3 coating the cells. You can have complement fixation that occurs because of dextrose in IV solutions. So that can sometimes cause a false positive in the sense that the deposition is not happening because of an antibody that's mediating the process, but because of dextrose solution in the IV. Some bacteria can cause T activation of the cells, which can then lead to there being evidence of either IgG or C3 on the cells. And over-centrifugation of the sample can just stimulate all the cells to stick together too tightly and get a positive result because of that. So those are all some reasons for false positive. On the other side, you can get false negatives for different reasons, and some of these are IgA or IgM coating the red cells. So these reagents, they're anti-IgG or anti-C3 specific. So if you had an autoantibody that was IgM or IgA or IgM subtype, and if it wasn't fixing complement like with the IgM, you could have a DAT that's negative, but they're actually being an antibody coating the red cell. Incubation after the Coombs reagent's added can also cause a problem. So the Coombs reagent can actually just dissociate. So it initially binds, but then will just dissociate. And so you can lose, or you can have a misleadingly negative reaction because of that. Some antibodies, autoantibodies, can be low affinity, so they don't stick very well to the red cell surface. And it takes very little manipulation in the test tube. For example, room temperature saline rinses to just wash them off. So they actually are stuck to the red cells, but by the time you test them, they're gone because of the storage or the way that they're treated and handled. So that can lead to a false negative. low surface concentration of an antibody on the red cell surface can affect things. So the Coombs test itself has a limit of detection of about 150 IgG molecules on the outside of the red cell. So if there's antibody coating, but it's below that, the DAT will be negative. And then finally, a highly lytic antibody could potentially cause a falsely negative reaction if the red cells that are contacted by the antibodies just get lysed completely. So you may have such dramatic lysis that the Coombs test is actually negative, even though there is an autoimmune antibody process going on. So to go back to question one with the options that are there, we're looking at what could cause a false positive. So that's this side of the table here we talked about. So that's the in vitro coating of RBCs by complement. So this could result in a positive test, even though there isn't really any in vivo coating. All the other options here is the presence of hemoglobin S wouldn't be expected to cause in vitro agglutination. And then these two options would actually be expected to cause false negatives, not false positives. So the A would be the best answer here. Which of the following statements regarding the direct Coombs test is true? So it was developed to diagnose autoimmune hemolytic anemia. The strength of the direct Coombs test correlates with severity of hemolysis. Test can be negative in autoimmune hemolytic anemia, or the test was invented by Professor Coombs. As forewarning, I don't think anyone's going to like me when they hear the answer to this one, but go through it. So fairly split responses. 28 people think it was developed to diagnose autoimmune hemolytic anemia was the best answer. 29 saying it was invented by Professor Coombs is the best answer. Test being negative in autoimmune hemolytic anemia is the next best, and then strength correlating with severity of hemolysis by a few people. So a bit about the Coombs test. So it was a test that was developed by a group. Coombs, Morant, and Race was the first paper that described it. So I think Coombs is often credited with it, but the first paper technically did have a few other people on the paper describing the use of it. And it was developed not with the intention of diagnosing autoimmune hemolytic anemia, but actually to try and solve this problem that they were noticing with these blocking Rh antibodies, and to try and understand whether some serologic issues they were seeing with Rh antibodies was due to Rh antibodies binding but not causing agglutination. That's what these blocking antibodies were called. And so they come up with this idea of using antibodies against antibodies to try and detect that phenomenon from happening. So it wasn't really developed to diagnose autoimmune hemolytic anemia. It was developed really to kind of solve some serological issues they were dealing with in studying red cell antigens. It became adapted for the diagnosis of autoimmune hemolytic anemia, which was at the time called acquired acholeric jaundice, by Mollison and Lutti. So it was not originally developed for that intention, but became adapted for it. And important to emphasize that the strength of the Coombs test really just correlates with the amount of antibody coating the red cells, and not with the amount of hemolysis or of lysis or lytic potential that the antibody has. So this is this study from the 80s of Mary et al., where they showed that the strength of the DAT really correlates with the amount of IgG that's deposited. And there's some radio-labeled studies that show that you can have very weak very weak DAT results at 1+ with short half-lives of the tagged RBCs, and 4+ results that have longer half-lives. So it doesn't really as strongly correlate with the strength. The amount of hemolysis doesn't as strongly correlate with the with the DAT strength. It's really a reflection of how much IgG is on there. So best answer here is that the test can be negative in autoimmune hemolytic anemia. As we talked about in the earlier question, IgA, IgM antibodies or low affinity antibodies could be explanations for negative. So false negatives are possible in autoimmune hemolytic anemia. And I think really put this question here just to kind of emphasize that the strength of the Coombs test doesn't correlate with severity of hemolysis. Question 3, which of the following tests are indicated for this patient? So again, we've got a patient who's got evidence of an autoimmune hemolytic anemia and has previously been transfused. So we have options here, red cell phenotyping by a few people, red cell genotyping by few people, autologous adsorption by a few people, and then both B and C. So that would be red cell genotyping and autologous adsorption. So important to emphasize here that the patient was transfused RBC 6 weeks ago. So autologous adsorption wouldn't be a very good option in this patient because of the history of transfusion. Between red cell phenotyping and red cell genotyping, since we can't pick both of them, the red cell genotyping would give us the best answer in terms of like showing us truly what the patient's phenotype is, or predicted phenotype would be, to help us with transfusion, guiding transfusions. But we're not going to get those results back in quite a while. So practically speaking, I think the red cell phenotyping is going to be the best first test that's indicated. But acknowledging that red cell genotyping is also indicated as well. So you know, could pick either of those and be kind of reasonable. But practically speaking, I think phenotyping might be more helpful in the short term. Question 4, a phenotype is performed, and then the question is, which is more likely? There's two options here. More likely to get a false positive phenotype result, or are we more likely to get a false negative phenotype result? Here we're seeing the patient's phenotype being little c negative, big E negative, cal negative, JKA negative, and big S negative. So this really kind of goes back more to just the patient's history than anything, you know, sort of in the lab that you need to know about. And I think most people got this right, which the false positive results are going to be more likely to be present than false negative results. And this gets back to the fact that the patient was transfused previously. So any antigens that are expressed on the transfused cells that were not expressed by the patient would be considered false positive results. And so that's more likely to be picked up than a false negative result where we would be not detecting an antigen that is actually there. We're more likely to see any reactions here that are positive. We have a risk of actually those being representative of the transfused RBCs and not the patient's own native antigen expression. So answer A is kind of the better of the two here. All right, so getting into alloadsorptions now. So have a few cells that are being considered as possible adsorbing cells for alloadsorption. So the goal of the alloadsorption here being to try and remove the autoantibody to help guide selection of RBCs. And we have these 4 cells that we're considering for alloadsorption. So for an allogenic adsorption with ZAP, with ZAP, so that's what we said, which of the following cells could be used? So cells 1 and 2, 2 and 3, 2 and 4, or 1 and 4. In terms of responses, we had a bit of a mix of responses, most answers clustering around either 1 and 4 or 2 and 4, and a few answers with 1 and 2 or 2 and 3. So how do we approach this? So again, just going back to alloadsorption and what it does. So the adsorbing RBC removes the autoantibodies from the test serum. So we've got here these triangles showing us the autoantibodies in the test serum. And because of these autoantibodies reacting with all of the panel red cells, we just can't tell if there's any other antibodies that are there that may or may not be kind of there, these blue blocks shown with the uncertainty shown by the question mark. And when we're using allogenic red cells, so red cells that might express antigens that are different from the patient's own red cells, they could be removing antibodies that we just don't know are there, and we don't know they're being removed. And so there's this risk of removing these alloantibodies whenever we're performing an alloadsorption. And that same risk isn't there when we're doing an autoadsorption because it's the patient's own cells, and so by definition, it can't be removing alloantibodies. It can only remove the autoantibodies. So to get around this problem with alloadsorption, we need to use at least 2 adsorbing RBCs that have complementary antigen expression. And by complementary, meaning that whatever's on one of the cells should be missing on the other cell, so that if you're removing it with one cell, you're not going to remove it with the other cell. So as a little cartoon here, we got our RBCs are going to be being used in the alloadsorption. They're going to take away our alloantibodies, or our autoantibodies, and remove them and leave behind any alloantibodies. But if we have adsorption happening with, this animation is going to work out, happening with red cells that express an antigen that the alloantibody sticks to. We're going to potentially remove that remove that. Doesn't show up in animation. These should be missing. Remove that completely, and we'll trick ourselves into thinking the person doesn't have an alloantibody that they actually do have. That's a concern. So when we pick the cells for alloabsorption, we want to be very mindful of that. And as I mentioned, making sure that we're picking cells that are kind of complementary. Because we're using ZAP treatment, ZAP knocks out KEL, Duffy, and MNS antigens. So any cell that's expressing is essentially going to be rendered negative for those antigens. So they're not at risk of removing any antibodies in those particular systems. We don't really have to consider them when we're looking at selecting cells. So they're blocked out here because of that. So what we want to focus on here is then picking cells that are going to have antigens that are antigen expressions that are going to be complementary to each other, or at least at the very least that if one of the cells we're going to use has an antigen, that we're not picking a cell that also has that antigen as the complementary cell. So if we look at the combinations that are possible here, I've just circled the antigens or the cells that are positive for the antigens that we're worried about here in the systems that are going to be left over after ZAP treatment. And so cells 1, 3, and 4 all express D. So we shouldn't be pairing any of those up with each other, because we could potentially miss a D antibody by doing that. If there's an anti-D antibody that's there, we won't be able to pick it up. It'll be absorbed away by these cells. So 1 and 3, 1 and 4, and 3 and 4 together aren't good options. Same rationale, pairing up 2 and 3 is not a good option, but this time for the little c antigen. And any pairings of 1 and 2, 1 and 3, or 2 and 3 would not be good options because of JKB. We wouldn't be able to differentiate those. So that really only leaves us with the option of using cells 2 and 4 as the absorbing cells together, because between the two of them, we're then going to leave behind any potential antibodies against these systems that could be used. When you look at the patient's phenotype, you might say, well, do we really care about the D positivity because this patient can't make an allo anti-D? But we don't know that. We don't know if this person is a D variant. So the safest and cleanest way of doing this would be to try and rule out any allo antibodies that could be made, not just looking at the patient's phenotype. So best answer C, 2 and cells 2 and 4 for the rationale we just went through. Question 6, which of the following antigens would not be destroyed by ZAP? So options here being JKA, D, F, or all of the above. Again, reviewing responses here, all of the above picked by most people. A few people picking some of the other answers in there. JKA most commonly is the next one, but I think most people on track with this one. So what is ZAP treatment? So it's a mixture of papain and DTT. Destroys antigens in the KEL system, the MNS system, and Duffy A and Duffy B. And so after treatment with ZAP, you'll remove those antigens, and so any allo antibodies against those systems won't be absorbed onto the absorbing cell. So all of the above is the best answer there. JKA, the KID system, D, and F, also the RH system won't be affected by ZAP. All right, question 7. So we have 2 adsorptions are completed. The patient's plasma is showing reactivity against all the panel cells and the patient's ZAP-treated cells, despite those 2 adsorptions. So which of the following is the correct interpretation of those findings? A, the patient's got multiple alloantibodies and identifications required. So not just the autoantibody, but now we've got multiple allos. Alloantibodies are excluded, and we just have residual auto. The ZAP absorption failed, and we'll have to look to do something else. Or there's some residual autos, and we need to continue with additional ZAP absorptions further. So in terms of responses we got here, most people picking that should just carry on with ZAP, but need to do additional adsorptions. And next most common answer being that ZAP adsorptions failed, and we'll have to try other techniques. So principle behind alloadsorption with ZAP, or the method that's used, this is adapted from the technical manual. So you mix ZAP with the adsorbing cells, incubate for 37 degrees for 30 minutes, wash away with saline, and then mix the RBCs that have been treated with ZAP now with equal volume of patient serum and incubate for 30 minutes. Centrifuge, and then collect the supernatant serum for testing. tested against the untreated RBCs. And this step is looking to see, is there any autoantibody that's left behind, or if we cleared up the autoantibody through the adsorption step. If it's still reactive, then we need to repeat until we have no reactivity. So in this case, we've gone through, we have the patient's reactivity against panel cells and against the ZAP-treated cells, the ZAP-treated cells, sorry. So we should be worried that we haven't effectively removed the autoantibody and continue performing ZAP adsorptions until we're getting negativity with the ZAP-treated cells. Sorry, against the patient's cells, not the ZAP-treated cells. All right, so question 8. Additional adsorptions are completed, and we're able to finally rule out alloantibodies. A unit of ABO compatible RHD negative red cells are selected for cross-match, but the cross-match is incompatible. Which of the following is true? The unit can just be issued with notification of the requesting service that it's incompatible. Just let them know, but we're not too worried about it. Additional units should be cross-matched until a cross-match compatible unit is identified. We are worried about this cross-match incompatibility. We got to keep looking for other compatible units. We should contact the most responsible physician and try and discourage them from actually transfusing the patient, because it's going to be difficult to find a cross-match compatible unit. Or we should continue doing some red cell panels to make sure that we haven't missed any low frequency antigens that are causing the cross-match incompatibility. In terms of responses here, I think most people on the right track with this one, with almost everybody picking the unit can be issued with notification of the requesting service of the incompatibility. Principles behind this one, really just wanted to emphasize that concern about transfusion safety in patients with autoimmune hemolytic anemia can actually lead to harm. There's this case series that was published a few years ago with this description of 4 cases of patients who actually died because of attributable to delays in transfusion support with their autoimmune hemolytic anemia. And this kind of narrative here sort of emphasizing that this sad case of a young patient who died with hemoglobin less than 20 in our units due to circulatory failure. By the time they'd taken, they actually had avoided transfusing completely, decided taking it for a splenectomy, but had eventually died of circulatory collapse because of that. So really that avoiding transfusion can be quite harmful. And there is evidence to suggest that transfusing patients in autoimmune hemolytic anemia is okay from both an efficacy point of view and a transfusion reaction point of view. So some data support that. There's this large study of 450 patients who were diagnosed with autoimmune hemolytic anemia who were anemic and transfused, and the transfusions were selected using the least incompatible method. 60% of these patients were actually transfused, 2,500-ish units given, and transfusion reaction incidence of only 1.6%, which is not out of keeping with reaction rates for other patient populations who don't have these incompatibilities. So that's some evidence to support the safety of transfusing despite cross-matching compatibility in hemolytic anemia. And in terms of the efficacy of transfusion, there's this nice study that looked at 160 patients that were transfused anywhere from 1 to 5 RBC units. And they compared these patients with patients that had a negative DAT but alloantibodies that were detected, and another group of patients that had no antibodies and a negative DAT. And you can see that they looked at days 1 through 7. You can see that the average change in gram per deciliter, so this multiply this by 10 to get our units that we're using, for every 10 mils a kilogram of RBCs that were given, we're actually not statistically significantly different across the 3 groups, except for by day 7. There was a bit of a decrease in actually patients with alloantibodies, not with a positive DAT, so a bit of a lower response in that group, not in the patients with autoimmune hemolytic anemia. So suggesting that transfusing cross-matching compatible units for patients that have autoimmune hemolytic anemia and where you've ruled out the other alloantibodies is an okay practice. So when we go back to this question stem, like what's going on here? So you've got the ZAP adsorptions completed. We've ruled out any other alloantibodies. We're expecting the cross-match to be incompatible because we haven't done anything about the autoantibody in the patient's their own plasma, right, when we're repeating the cross-match with the non-ZAP treated plasma. So that's not a surprise. We just want to make sure that the requesting service is aware of the incompatibility and mostly just as a way that they're not going to raise eyebrows and worry that we've issued them something that we shouldn't have issued. That's the best answer there. And I guess with that, that's the last case. Hopefully, I guess we can open it up if there's any questions or comments. Don't see anything pending in the chat. Hey, is that right, Tracy?
No. No. So again, if you have a question, you can raise your hand and we will unmute you to ask the question, or you can just type it in the chat. Again, I think you answered everybody's questions.
All right, that's great. So, apologies for a few of the typos in the questions. I hope that didn't cause too much strife for people completing them. There's no other questions. Well, I guess just thank everyone for the participation in the workshop, and hopefully it was a good exercise and some learning points for people to take away from it. If there's any questions, I guess, about it, I guess you can direct them to Tracy. Is that the best way to go about it, Tracy?
Yeah. Yeah.
Okay. I think everyone should have your email from the registration process.
I hope so. If not, I'll put it in the chat just in case.
Super. Right. Thanks everyone for joining.